I just like, I had this
Oh, that's great.
It's very festive. I love it. This is the last one before Christmas, isn't it?
Perfect.
Yeah.
Yes. Oh,
but you know, you might not know that I wear this to every round. So just try not to miss it.
It's not just a Rudolph one. That was excellent. Good start. Today we're talking about diabetes insipidus and adrenal tumours, which are kind of not really related, but we can kind of link them because both cause PUPD. So we'll say that they're sort of related, but really we're just wrapping up the endocrine section of our discussions. I would much prefer, I think adrenal tumours, we're talking about sort of a whole heap of different processes. And so I want to leave that to the end. And while we're a little bit fresh, go through more of the kind of physiology of diabetes insipidus and how polyuria develops, with a little bit of reference to kind of renal physiology, which is our next topic. So we're sort of going to, I really want to make sure we cover that today with reference to PUPD and endocrinopathies so that we can then segue into renal in next fortnight. Did anybody do any pre-reading for this? No. Cool.
Not this time, sorry.
No, that's all right. I'm going to ask you questions, but throw them back at me if you don't want to answer them for sure. What is diabetes insipidus?
The non-function of antidiuretic hormone at either end.
Yep. What are the ends?
Yeah, so you've got like primary diabetes insipidus where you don't have release of ADH or production of ADH.
Yep.
Then you've got secondary nephrogenic, which is secondary nephrogenic, which is either primary or acquired.
Good.
That's the terms. And primary is where you have it's a congenital issue as well, but the ADH receptors in the kidney are not there or functioning.
Yeah, excellent.
Acquired is when there's something else going in the body that's affecting the function of those receptors.
Great, excellent. That was very well done for no pre-reading. Excellent. So primary central was the only word you didn't say there. So central diabetes insipidus. Yeah, but I knew what you were getting at with the primary, which is a deficiency of ADH, which can be complete or partial deficiency. Primary nephrogenic, which is the absence of receptors or congenital malfunction of receptors, which usually presents very early on. PUPD is present from birth. And then there's secondary nephrogenic, which is the malfunction of receptors due to usually other systemic problems. So the reason why I've sort of wanted to leave diabetes insipidus discussion till the last topic in endocrinology is because a lot of the endocrinopathies cause polyuria via some impact on the ADH receptor. So I just think it's a nice one for us to have all the background on the other endocrinopathies to sort of start this discussion. But can anybody tell me what ADH does in the body, in health?
Oh gosh. It regulates potassium to an extent and sodium volume, sort of sodium and potassium.
It's not actually, it's more free water movement rather than electrolyte movement. So aldosterone, the renin-angiotensin-aldosterone system does more of the electrolytes and obviously the kidney function, but it's free water movement throughout. So does it cause retention of water or loss of water if you've got an increased ADH level?
I think it causes.
Think about the name.
Retention.
Good. Antidiuretic. So it's almost, for me, I don't know why. Yeah. So it's the opposite of diuresis. So we get fluid retention when there's increased ADH. For me, antidiuretic feels like a double negative. Like I really have to think about it. When you get suppression of antidiuretic, I'm like, ooh, there's 3 negatives here. So I don't know why I find it conceptually hard, but I'll probably just come back to that. And then the other light bulb moment that came very late in my study, which I want to share with you all. Does anybody know what the other name of ADH is? Yes, good. Because the chapters are written by different people. One person will use ADH consistently, and another person will use vasopressin consistently. And I just didn't make the connection for a really long time. So you too? Oh,
yeah, it was only like last year that really kind of clicked. I was like, okay.
Oh.
Exactly the same. I thought maybe they were like doing similar things or something, but
yeah. So knowing what we use vasopressin for clinically, what other effect does ADH have in the body?
Vascular tone.
Beg your pardon?
Oh, sorry, vascular tone.
Good, excellent, yeah, excellent. So it causes fluid retention at the level of the kidneys and increases vascular tone via there's two main receptors. There's 4 receptors it has impact on, but there's 2 main receptors. So the V1A receptor is in blood vessels, causes vasoconstriction, and the V2 receptor is in the collecting ducts of the kidneys. This is a stretch question, fellowship question. What is the mechanism of action at the level of the collecting ducts of the kidneys that vasopressin or ADH increases fluid retention?
Does it make, this is way out in left field, one of them makes like aquapores?
Yes, that's it. Well done, Sam.
Yahoo!
Yahoo! So when ADH binds to the V2 receptor, there's these pores that are sitting inside the cell and they get relocated into the cell membrane. And the name of the pore is aquaporin. It's aqua comes pouring in. So that essentially just makes a little channel in the cell membrane that allows free water to move from the tubule into the interstitium in the medulla. What dictates movement of fluid from one space to another?
Pressure, osmotic pressure and hydrostatic pressure.
Good.
Like fluid
Excellent.
pressure.
Yes,
Yeah.
perfect. So for fluid to move from the tubule into the interstitium to be then sucked up into circulation again, what are we reliant on in the medulla?
The medullary concentration gradient, like
Good, excellent, yes. So hypertonicity of the medulla. What chemicals or what are the things in the medulla which create the hypertonicity?
said urea and glucose.
Good, urea, and shouldn't be glucose in there.
Oh yeah. No.
The urea was the main one.
It's the main one, yeah. And if you ate it, what would it taste like? Sorry.
ammonia.
So sodium.
Sodium, okay. Salty.
Sorry, that was a bad clue.
Yeah, probably tastes really gross.
Don't eat it is the key. Yes, so we are heavily reliant. ADH causing fluid retention is completely reliant on having a hypertonic medulla. In what situations do we not have a hypertonic medulla?
IV fluid overload.
Good, excellent. Yep, absolutely. Iatrogenic.
I know there's some some diseases will do it, but I
Mhm.
don't know which ones. I mean, anything that will cause low urea will,
Ooh, tell me more.
which can be liver disease because
Good.
that's one of the cause.
That's exactly what I'm getting at. Yeah. So if we've got low urea or low sodium, we are going to have decreased medullary tonicity and decreased responsiveness to ADH. So if we're going to diagnose this patient with diabetes insipidus, what type of diabetes insipidus is it going to be?
Nephrogenic.
Primary, secondary?
Acquired.
Good. Secondary. Good. So the nomenclature is not consistent across the literature. So primary or secondary versus yes, acquired is also used. So yeah, you can either use secondary or acquired. Good. What happens when ADH levels drop again? So there's enough fluid. Oh, let's go back. What stimulates ADH secretion?
Osmolality, isn't it? Is it like a decrease of osmolality? No.
It's not actually osmolality. It's pressure and volume receptors.
The baroreceptor
Oh,
stimulation.
Good, yeah, exactly. So there's baroreceptors and volume receptors in which part of the brain?
Are they in the carotid?
Oh, there are baroreceptors in the carotid, but they're more associated with sympathetic nervous system function and heart rate and things.
So then hypothalamus, is it?
Yeah, hypothalamus, exactly. So these little receptors sense volume in the hypothalamus and will secrete ADH in response to a drop in blood volume, which then results in vasoconstriction very appropriately and fluid retention also appropriately. So then my question was, what happens once you've got enough fluid? I'm just going to tell you, sorry. So once the ADH has done its job and we're rehydrated, volume is normal again, ADH dissociates from the receptor and the aquaporin channel just goes back inside the cell. It's really cool.
Wow.
Yeah. So if you've flooded the patient, so say you've given desmopressin to a patient and heaps of aquaporin channels have gone into the collecting ducts and heaps of free water has flowed from the tubule into the interstitium, what's happened to the tonicity of the interstitium?
It's become diluted.
Exactly. So ADH works really well short term, but only when it's intermittent. You can't just leave those aquaporin channels in and expect to get the same effect because you'll lose that movement of fluid. Make sense?
Mm-hmm.
Cool. All right. Let's talk quickly about what causes central diabetes insipidus.
Any trauma to that part of the brain, neoplasia?
Yep.
I don't know if congenital, like how often do we see that? Like textbook, yes, but
Pretty unusual. Yeah. What?
will hypophosphatemia cause it?
Good. Yeah, exactly. That's probably the most common cause of trauma to that area of the brain. So often have to supplement hypophosphatemized animals with desmopressin. What about neoplasia? Do we ever see that? Or could we? So usually metastatic. Reported with mammary carcinoma, pancreatic carcinoma. I don't think it's reported with pituitary tumours, but that would make sense to me as far as like something sort of pushing up on it. But yeah, so moral of the story, if it's not a congenital one, worth doing an MRI if you haven't taken the pituitary gland out. Okay, that's all I wanted to cover with central. Does anybody want to talk about that anymore?
They're the ones that as well, they respond best to desmopressin as well, don't they?
Good, yeah.
They get to nephrogenic.
Yeah, absolutely. So they're primed and ready for ADH in their system, and you just got to give it.
That's interesting as well, like with the aquaporins, like I wonder, treating those, like if you are treating them for longer, do they just get harder to manage? I've never really never seen one really. So
Yes. So I think it's so short acting that if you're dosing twice a day, then you're still going to kind of have a break where the aquaporin channels go back into the cell. You're not going to be like continually.
Sure. Okay.
Yeah, it's just still going to be pulsatile.
I guess the
Okay.
biggest risk is they just become dehydrated mostly, isn't it?
Beg your pardon, sorry.
The biggest, one of the bigger risks is they just become dehydrated, isn't it? So I guess it's not so bad.
Yeah, exactly. Yeah. As long as you give them a chance to rehydrate, like normal hydration status goes like this throughout the day when you have a drink, and then busy day in the clinic, didn't drink any water for 12 hours, came home, drank a bottle of wine. Hydration status definitely fluctuates.
Yeah, for sure.
So let's talk about primary nephrogenic. We sort of said that that's predominantly congenital. Has anyone ever seen it?
No.
I haven't. It's reported in huskies, German shepherds, poodles, Bostons, and elk hounds, which we don't see very many of. But as we said, the PUPD is present from birth, and you're going to be pretty suspicious. Like, you know, a patient that's presenting at 8 weeks old with profound polyuria, polydipsia, you're going to have it on your radar. How would you diagnose primary nephrogenic? Let's talk about diagnosis after we've talked about secondary nephrogenic. So let's talk about secondary nephrogenic. What will cause decreased ADH responsiveness at the level of the kidneys?
No, hyper it does. Like
Say again.
hyperadrenocorticism does.
Yes. Yeah. How come? It's a trick question. Sorry.
Mechanism, I'm not sure. I just know it does.
No one's sure. Sorry, I'm just getting a pencil so I can mark off my list as we go. Okay.
Pyometra is another one, like E. coli does something to the.
Good. Let's go back to hyper A just quickly, just because there's two actual mechanisms of the polyuria in hyper A. Actually get decreased ADH production. Like if you measure ADH level in hyper A dogs, they've got central diabetes insipidus, and they've also got decreased responsiveness at the level of the kidney. So they're interesting, but we don't really know why that happens. Okay. E. coli. Tell me more.
I think you mentioned pyometra, didn't you?
Yeah. Why though?
Something E. coli does. I don't know what though.
So it's actually gram negatives. It's endotoxin.
Oh,
And E. coli is obviously the most common.
common one. Okay.
Yeah.
So it can be any other as well. Not
And,
this.
yeah.
Okay.
So endotoxemia of any cause. So we've seen dogs with UTIs with PUPD, dogs with gallbladder infections, pyelonephritis. Obviously, there's a couple of reasons for polyuria in that situation. But certainly E. coli or gram-negative infection causing sepsis will result in decreased responsiveness of the ADH receptor, because the endotoxin actually binds to the receptor and blocks it.
So, Anna, is that the mechanism? I just had a light bulb moment when Jeff said pyometra.
Yes.
Is that why pyometras are always thirsty?
Yes, exactly. They've got such a huge E. coli load usually.
I've learned all month.
And it's the first thing, did you say? Or the best?
The best thing. I've seen lots of pyos overseas too, and I always know they're thirsty, but I never connected this as to why.
Yes, yeah. And it's a nice thing, you know, we're trying to be really responsible with our antimicrobial usage. If you've got a polyuric dog with an infection, probably E. coli, and you can be pretty selective. With your antibiotic choice. Any other causes of nephrogenic secondary?
liver disease.
Yes. We talked about why. Tell me again.
Did we talk about what is that?
The urea, it changes the medullary content.
Oh, of course we did, didn't we? Yeah.
Yeah.
I remember now.
George is in holiday mode.
No.
No. So
But then it has to be liver dysfunction, not really disease, like in the sense failure, not just dysfunction.
yes, exactly. Yeah. So the other thing that liver disease can potentially do is cause hepatic encephalopathy, and you can get some psychogenic polydipsia as well as a nephrogenic diabetes insipidus. So there are situations where you might have liver dysfunction but a normal urea where there still be polydipsic polyuric. So it's not just the one mechanism, but it's the one that demonstrates my point. So we're going to talk about that. So that's something I want you all to leave this tutorial with is for ADH to work, you need medullary hypertonicity.
Well, I found an area sort of
I guess.
Beg your pardon?
So hyponatremia is probably another one, I'm assuming.
Yeah, good. Yeah, absolutely. Okay, what about Addison's? Why do we get polyuria in Addison's disease?
Hyponatremia.
Good, excellent. What about hypothyroidism?
Hypothyroidism doesn't cause hyper.
Hyper,
More. Okay.
high, yeah,
Yeah.
in cats.
I don't know. I'm assuming it just increases GFR to some degree. Yeah, but I don't know why exactly, if it's just thyroxine directly acting on the.
What happens if you give too much fluids to the medulla?
You're going to dilute it.
Wash out.
Wash out. So the mechanism of that is increased GFR. So if you've got increased GFR associated with hypothyroidism, you're going to get medullary washout, and then you're going to get decreased urinary concentrating ability or decreased effect of ADH. What about calcium?
Oh yes, hypercalcemia.
It can be the cause and the effect of renal disease. It's the same.
Yes, yeah. Absolutely. So calcium actually directly blocks the ADH receptor as well and stops ADH binding to the receptor. So with hypercalcemia, you get decreased ADH efficacy. I think that's all I wanted to cover. Does anybody have any other diseases they wanted to talk about mechanism of polyuria?
Does like post-obstructive diuresis fall into that as well, or is that a whole different? Just wondering if that's just like injury to the interstitium or something.
Such a good question. I wonder whether because of the increased hydrostatic pressure, we've got medullary washout because of increased fluid movement into the medulla, but I don't actually know. That would be my guess.
There'd also be a build-up, wouldn't there, of toxins in the blood that the body would need to get rid of fairly quickly. Would that have an effect?
And you'd have increased blood volume because you've had decreased GFR, and then so you've got more to get rid of as well, and then you get medullary washout. The other thing that's kind of a little bit complicated and not, it's kind of peripherally related, but hypokalemia actually causes polyuria as well because it decreases urea transporters and decreases tonicity because of its impact on urea, which is a little bit complicated and I don't really understand it very well. But if you've got post-obstructive diuresis, you've got loss of potassium as well as medullary washout and increased GFR, then that's probably enough mechanisms. But I'm sure it's more complicated than that. Maybe we'll get to it in the urinary section. I'll tell you in February. So if we kind of try and apply our new knowledge to a patient who is an 8-year-old female D-sex dog who presents with polyuria and has had Cushing's disease and all the common causes of polyuria ruled out, blood tests are pretty much normal. What are our remaining differentials on the list?
Well, stump pyo would be a consideration. I'm not sure whether you've already ruled that out or not.
Yes. So what I want to do is kind of get, rather than looking at the smaller diseases which might be causing it, I want to get people sort of clinically thinking, I've got a polyuric dog that doesn't have Cushing's disease or one of the sort of common, you know, it's obviously not in liver failure. What are the broad mechanisms that could be causing polyuria? So we've got remaining on our list, central diabetes insipidus, nephrogenic, probably not primary, probably secondary,
Or
diabetes insipidus.
are you meaning behavioral, like psychogenic
Or
polydipsia?
psychogenic polydipsia, exactly. So they're the three really that we've got left on our list. And partial nephrogenic diabetes insipidus is almost always the case, and then you have to go hunting for the other diseases. But how do you differentiate between those three diagnostically?
Modified water deprivation, like is that what you would do?
Good. Yeah. Does anybody have a test protocol for that, or is anybody comfortable doing that?
No,
Yeah.
I would assess the response to vasopressin.
Good. Yeah. Yep.
Because
So
if it's
that's-
renal, it's probably not going to respond very well.
Good. Yeah, excellent. So that is one of the kind of recommendations for a modified water deprivation test, is do a 1-week trial with desmopressin. Let's play out a couple of different scenarios. So say we were going to do a modified water deprivation test and we actually were going to deprive a patient of water. They've been chronically polyuric, so they've probably got medullary washout. So then we're going to dehydrate them, looking for the urine to become concentrated. What's the problem with that plan?
You can cause massive shifts and like dehydration, and they can die. So you have to be very sort of vigilant. You can't just leave them. And you
Absolutely.
have to keep
So-
checking. I mean, if I ever had to do it, I would look it up, but you have to keep checking
Yeah.
weight loss, because that's one of the weight, like you need to
Yeah.
keep checking weight, because that's one of the gauges to see how
Mhm.
much water loss there is.
Yes.
You might get some false positives though, I imagine, as well.
False positives, as in like falsely failing to concentrate.
Yeah.
Yeah, absolutely. So we might have a dog that can respond to ADH, but because they've got medullary washout, they can't respond to ADH. So they're going to get really dehydrated before their urine gets concentrated, and we're going to have to abort our test. But if we pushed it, then they would have eventually been able to do it once the medullary hypertonicity is restored. So the theory behind doing desmopressin for a week is that you give the patient a chance to restore their medullary hypertonicity, because you're kind of giving them a chance to not be polyuric the whole week. Does that make sense?
Yes.
So if you restore that medullary tonicity before you do your actual water deprivation test, then sometimes you don't even have to do your deprivation test. They come in the morning and they've got a concentrated urine. You can say, okay, you have concentrating ability. You don't have an ADH deficiency, and your kidneys can respond to ADH, your own ADH, or the desmopressin you've given. I don't think I've explained that very well. So this patient, we give it desmopressin for a week. And it comes in and its USG is still under 1030 in the morning. And so we decide to actually do a water deprivation test. We've got a urinary catheter in, we're monitoring weight, we're monitoring sodium, we're monitoring urea. for dehydration and PCB, TPP for clinical dehydration to develop. And we're doing a USG every hour without providing the patient with water. And we get to the end of 8 hours, the dog is too dehydrated, we need to abort the test, but the USG is still under 1030. What are our options now? What are our differentials remaining on the list?
Imagine it's probably more nephrogenic.
Mm-hmm.
But we can probably rule out central.
Yeah. Because this dog's had desmopressin for a week already, so it would have responded to that if it was central. So what would you do at the end? So you've kind of dehydrated this patient. Right before you give it water, what could you do? You've sort of given it a chance for the medullary tonicity to be restored. Would you give it another dose of desmopressin just to check what happens to the urine concentration?
Yeah, I guess that's
Maybe, yeah,
probably
just to-
good to retain any further water for them anyway. So I can't see that causing harm.
Yeah. So it's exactly what sort of one of the test protocols recommend. So you can give a dose of desmopressin. Right before you do that, you can actually measure their ADH levels. So if you've got central diabetes insipidus, what's your ADH level?
Should be massive or really high. It's trying its best to retain water, but it's just not being heard.
Central diabetes insipidus?
Oh, sorry, nephrogenic.
I thought
Yeah, central would be low, or
I knew you knew that.
inappropriately low.
Yeah. So central ADH is going to be low. Nephrogenic diabetes insipidus, what's the ADH level going to be?
Be very high.
Very high.
Oh,
Exactly.
this one.
Yeah. So it's a nice differentiator. Then when we give our desmopressin, we measure and the urine all of a sudden is very concentrated and we can give our dog water and the job's done. Realistically, most of these are partial and they concentrate to sort of 1028 and you're thinking like, God, why don't these kidneys want to respond to the ADH? And they just need more ADH.
Can you measure ADH in Australia?
You can. The human assay is completely appropriate actually for using dogs, not cats. I don't think. I'm not sure whether it's been done in cats. Yeah, I'm not sure about cats, but yeah, the human assay is very appropriate. So it's a nice addition even before you do a water deprivation test. If you're thinking could this be central or nephrogenic, do an ADH level. Good. So
And I'm assuming that you would, the ADH level is not that definitive, otherwise you'd never need to do a water deprivation test.
that's
Pre-test, like until you have really pushed the limits with your hydration.
yeah, exactly. So most of these dogs that have very high ADH levels, because they've got decreased responsiveness to ADH. So you get a lot of highs. If you've got a low ADH level, you know it was central, but the high doesn't give you any more information. So then you've still got to kind of work out how responsive their kidneys are to ADH. What else do we want to cover with this? So how is a dog with psychogenic polydipsia going to respond to what we've just done?
Well, I've got medullary washout, haven't they? So
They do, but we've given that a chance to reconcentrate.
okay, we've got that far. So
So
they should respond fairly well.
yeah, so it shouldn't need exogenous desmopressin. We should just see that USG gradually improving over the course of the day. We're gradually getting more concentrated. The trouble is that they've often got such severe medullary washout that if you haven't done that week-long desmopressin before going into the test, they often have decreased responsiveness to ADH. The other thing is that because it's a primary polydipsia, these dogs are constantly overhydrated. So what is their brain doing? What would their ADH level be?
Probably low.
Low, exactly. Yeah. So when you're doing your sort of water deprivation test, if you're not giving exogenous ADH or desmopressin, then their brain doesn't have as much capacity to release ADH, so they've got decreased ADH level relative to other dogs with a nephrogenic diabetes insipidus.
Is there a brain lesion? I forget. Is there a diagnosed lesion that makes you psychogenic polydipsic, or is it not understood?
Usually behavioural. It's a sort of anxiety related behaviour. Say again.
Like a compulsion.
Yes. Yeah. Exactly. Yeah. There are like syndromes of inappropriate ADH secretion and stuff. Sorry. And hypodipsic hypernatremia, like brain lesions that can cause changes in ADH and like primary thirst and ADH, but they're MRI jobs and they're usually congenital. But yeah, if it's an old dog, MRI, basically.
And you're talking about giving vasopressin for a week. Would it not be prudent to measure the? I think I nearly know the answer. I was going to say measure the ADH level before you start.
Yeah, absolutely, for sure. The trouble is we're trying to differentiate psychogenic polydipsia from like partial nephrogenic diabetes insipidus or central diabetes insipidus, and the ADH level might be low before you start in both central and psychogenic polydipsia. Yeah,
but if it was high before you start, there wouldn't be any point in giving a week's trial with it, would there? Or would there?
It's such a question. I think there is, just to decrease the medullary washout so that your water deprivation test is going to be more diagnostic. And to give these, so if you give, they might have decreased kidney responsiveness to the ADH, but if you give more, like double the amount of ADH, then you might get a response, and then you can say, okay, we've got partial nephrogenic diabetes insipidus just by definition. Does that make sense?
Yeah,
so it's kind of like
so. Yeah.
Patients that have an inability to absorb enough cobalamin, if you give them 100 times the cobalamin that they need, then they're going to end up with a functional cobalamin level in their body. Whereas if you've got kidneys that aren't responding, the brain just can't produce enough ADH, but if you give them 100 times what the brain's producing, you're going to get adequate kidney function. So you've just got to flood the receptors that are there, maybe.
Yep. The other thing, I mean, it's probably old information now, but I had read about using a modified water deprivation for 3 days before they actually come in.
To restore the medullary tonicity.
Gradually reduce the water intake at home before they come in for the. Is that a good idea or not?
The trouble is that these patients can get so incredibly dehydrated. And so we typically do the water deprivation aspect in a very tightly monitored situation. So I wouldn't usually do water restriction at home.
Yeah, it wouldn't be monitored properly, would
protocol. I do actually have a protocol kind of written out that I could share with you, Jeff, if you're interested.
Oh, I think I've got it.
Oh, good. Okay. Yeah, excellent. Yeah. So we usually don't restrict water unless we're monitoring them.
Yep. Yeah,
All
the
right.
other idea is a much better one.
Let's talk about adrenal tumours. Say you've got a polyuric patient. Cat. Oh gosh. Okay. There are so many different types of adrenal tumors. We could go down so many different rabbit warrens here. So say you've got a dog that's having an ultrasound and it's a 10-year-old dog and is there for a mild ALP elevation, and you see a 15mm diameter adrenal tumor. What are the differentials for that tumor?
Your
Adrenal
functional
tumor.
adrenal.
Sorry, go.
Yes, okay.
Adrenal tumor. I mean, you need to. I need more information, Anna. This is not enough information. What are the clinical signs?
Completely not clinical. There's no clinical signs related to this tumor.
It could just be an adenoma. It could just be
Mhm.
a cyst.
Mm-hmm.
As if
Could-
it's
could be
functional, you would see some signs. Like you can't have no clinical signs, which is why I'm saying it's
Good.
probably
Is
not.
it hypertensive? Is it
But
tachycardic?
It's
But
not.
if we are saying no signs, then it's not hypertensive, I'm assuming.
Yeah,
Could it be
Maybe
metastatic from somewhere else?
could be. Yeah. What's
be
the most
cancer.
common tumor that metastasizes to adrenal?
Hemangiosarcoma?
Oh, I'm not the most common, but it could easily because it tends to go
Just
everywhere.
a carcinoma.
Carcinoma, lymphoma, interestingly.
Lymphoma.
Yeah, lymphocytes are found in adrenals in a lot of, like 25% or something of patients with lymphoma. Good. So essentially, like category wise, because I'm dealing with this a lot doing ultrasounds, we find these little tumors and we call them incidentalomas because they're incidental findings with no clinical signs, but they're not uncommon. There was a study of incidentalomas, which was really small, so I don't really trust the stats, but 3 out of 7 regressed and went back to normal size over the course of like a 3-month recheck. So if you're just seeing an incidental finding adrenal tumor, I guess clinically, what do you do about it? Do you go down the route of testing for a functional tumor? So doing adrenaline or catecholamine metabolite testing plus low dose dex suppression tests for Cushing's, or do you just sit and wait and repeat the test?
I would sit and wait because, like, why? If there are no clinical signs, why would you want to do anything?
Yeah. And then the other option, which there's been another study done recently, is do we aspirate these? Do we?
I think that study, they're not so worried. And that's right. But
Yeah. Exactly.
historically, vets, including myself, are very worried.
Very worried.
But yeah.
So our concern levels are based on the incidence of complications with humans, which are between 30 and 70% of adrenal aspirates result in complications. But I think our patients just don't complain as much as humans do about tachycardia and hypertension, things like that. Our patients have quite wild swings in catecholamine levels. And the complication rate in dogs is less than 1% of adrenal aspirates. But again, when you only look at 100 dogs, it's hard to sort of say that those stats are exactly right, but quite well tolerated. So that is an option if it's big enough, can safely be accessed without damage to the kidney or blood vessels and all the rest of it. But most of the things we're looking for are going to be diagnosable via cytology. So carcinoma versus adenoma is usually, you'll have hallmarks of cell changes. They can often amazingly pick the catecholamine, like neuroendocrine tumors. So if it's a functional adrenal medulla tumor, they can usually call that cytologically. And with functional carcinomas, they won't be able to tell you that. That's a clinical diagnosis. So if we've got a cortisol secreting tumor or an aldosterone secreting tumor, they'll be able to say these are the cells are cortical, but they're not, we don't know whether they're secreting hormone or not.
But can you ever have a functional tumor without clinical signs? Like, is that even possible?
Do you know what percentage of phaeochromocytomas have clinical signs at diagnosis?
No, but I always thought like they have hypertension and they have something to hint.
So most of the time, well, how would a pheo present? Typically, you sort of mentioned some of the things already.
Like you would see hypertension. They can have they can present with a stroke or something, because then you go looking for it, and then it's like
Tachycardia.
Tachycardia, yeah, absolutely. So most common presentation is restless behavior. Only 30% are hypertensive on presentation. The tachycardia is so fluctuant that you're actually quite lucky to catch it in most patients. And most of them have GRT signs, so intermittent vomiting, off food sometimes, which, you know, when that feeling of like the adrenaline rush, they don't feel like eating when they're getting it. But adrenaline and noradrenaline are so short-lived that the effects are very transient and intermittent. So you might not see them when they present at the vet clinic. It can be quite a tricky thing to diagnose. And then the other thing is that they can be so small that ultrasound isn't necessarily, I mean, it's a good test, but it's not the best test for it. How do you test for a pheo?
It's norepinephrine, like your urinary catecholamine
Good.
levels.
Yeah, exactly. So it's quite an easy test to do. Get the owners to collect some urine at home, because obviously when a patient comes into the hospital, they get a catecholamine rush, and it just can make it a little bit grayer interpreting the levels. But these metabolites that Josh mentioned, do you know why we're measuring a metabolite rather than noradrenaline or adrenaline itself?
Because you just said it's short-lived, so we may not.
Good. Yes. It's kind of like the fructosamine of the glucose world, but for adrenaline and noradrenaline. And if you do the urine to creatinine ratio, the norepinephrine to creatinine ratio, it gives you kind of an average of what the catecholamine levels have been over the week to 10 days prior to testing. So it gives you a bigger picture rather than that kind of really fluctuant level that we see clinically. What are you going to do about a pheo if you diagnose one?
Do CT. If owner is wanting to, then do surgery.
Is Josh a surgical resident now? Just cut it out.
My eye just switched.
I put it on drugs before, but I know Keely doesn't like to do that. So
yeah, it's actually interesting. There's been a paper, so go back a step. There was a paper that was quite influential in terms of our management of phaeochromocytoma, in that the morbidity without pre-treating with the alpha-2 antagonists, alpha-2?
Alpha-1 and alpha-2.
Alpha-1 and alpha-2.
I think
phenoxybenzamine, I think.
Yeah.
Right?
Yes,
I think it's both,
exactly. Yeah. So this paper looked at if you pre-treat, mortality was like still reasonably high. It was like 20% or something. And if you didn't pre-treat, mortality was like 70-something%. So there was a trend towards making sure that the adrenal receptors had been completely blocked for 2 weeks prior to surgery, to make it safer. But there's been more studies since then that maybe that study wasn't that reliable, or it was a weird population or something like that.
Is Keely's justification for that, when I asked her recently, she was saying how he's like, well, I can do most of the things I want to do at anesthesia anyway.
Then and there.
So
Yeah.
I'd rather be able to control that.
Clean slate. Yeah.
Yeah.
Yeah, totally. And really, I don't know what effect, like how there would be that 2 weeks is such a kind of like somebody just pulled that out of the air. There's no data for that. So as long as you've got the medications and an anaesthetist to give the medications appropriately, then why not just do it then and there? Phaeos, if you've got a patient that's surgery is contraindicated, like it's metastasized or there's comorbidities, or it's like a 15-year-old dog or something like that, they actually do quite well with just the alpha adrenoceptor blockade. So survival is typically 12 months in patients medically managed, and obviously those patients are often very old and they end up dying of comorbidities rather than the Phao. So it does alleviate a lot of the clinical signs. You're just using phenoxybenzamine. There's a website. It's hard to find the dose because you can use phenoxybenzamine or prazosin, same thing. And prazosin's easier to get. Phenoxybenzamine you have to have compounded. So there's a website that it's hard to find a prazosin dose for a dog with Phao. There's a website that says this many milligrams per kilo. They mean per dog. Don't give per kilo. If it feels wrong, don't give it.
They still haven't corrected that website. That's
no, they still haven't. Did I do this? It's very scary. So I prescribed like a 15 times overdose to a dog who then went to sleep for 2 days and then woke up again feeling fine. Blood pressure, systolic blood pressure was about 80, and we were like, oh. But it was literally a very reputable website. It's just a typo, so I'm now extra careful with my reports and things when I'm putting doses in there and making sure I'm checking. Right, so we've done Phao. What about, obviously you know about adrenal dependent hyperemia, we kind of covered that a couple of weeks ago, so I don't want to go too much into that. What about an adenoma? Do we have to do anything about? No. What's the kind of markers if you got an ultrasound report and thought, you're trying to work out whether you need to do something about this or not? Are there any hints like size or behavior that would make you think, oh, I want to investigate this further?
I think size is definitely. I just don't know the exact size. I think is it 2?
25 millimeters.
25 millimeters. Okay.
Yeah, more likely to be malignant if it's over 25 millimeters. There's another study that says 50 millimeters. I'm like, if I saw a 5 centimeter adrenal tumor, I'd probably be worried. And I think the other thing ultrasonographically is if it's really smooth margin, it's very confined to one end of the adrenal gland. The adrenal gland's otherwise normal. There's no contralateral atrophy. And it's not sort of looking like it's got bright fat around it, it's not causing any inflammation, then I'm not going to worry so much. But if I see irregular margins, like it's looking like it might invade, or bright fat, then I'm going to be more suspicious of something a little bit more malignant or aggressive. And obviously metastatic is a possibility as well. I think that's pretty much all I wanted to cover.
Are we thinking with, sorry, Anna, with those incidentalomas, they're usually adenomas that regress?
That's a really good point. So adenomas probably wouldn't regress. One thing I've seen, which it was actually a Coringa patient, had an adrenal tumor, and it was 3 centimeters originally. And then we sort of sat on it for 6 weeks, rechecked it to see how fast it was growing with a view to aspirating it. And I came back and checked it, and it was like 15 millimeters. It had gone down by half. And it was so much less angry the second time I looked at it. And then came back again 3 months later and checked it again, and the adrenal was now normal size. Sorry, I shouldn't say normal size. The dog had cushings. So it was a big adrenal, but like bilaterally enlarged adrenals. But it looked completely symmetrical with the other one. And my theory is that dog actually infarcted its adrenal and had an acute inflammatory response and big, dark, bright around it. And then over time got circulation back and the adrenal kind of went back to normal. But I just can't think, unless we've got some sort of adrenalitis, fungal infections can go to the kidney, but typically so the adrenal, but typically aren't isolated to the adrenal. So we've got like the dogs with systemic aspergillosis might have an adrenal granuloma, but they've also got pyelonephritis and stuff and disco. And the other fungal diseases we just don't see in Australia. So anything that's kind of transient like that, I think it probably has to be vascular.
Oh yeah, okay.
Yeah. Or transient inflammatory. Yeah. And particularly when you've got an underlying condition that makes them hypercoagulable. But yeah, I'm not sure what causes them to regress. That's why I don't really trust that study. It doesn't make sense to me. Too few dogs. All right, I might wrap up. Thanks for coming, everyone.
Thank you.
Merry Christmas.
Thank
Merry
you.
Christmas
Have a
Thanks,
great
everyone.
Christmas.
and Happy New Year.
Yeah.
Christmas. Thank you.
Pleasure. See you.
Thanks. Bye.
Bye.
Anna,
Bye.
bye.
Bye.